Henry Ford Health System, like many other health systems, was looking for ways to strengthen collaboration and improve relationships between clinicians and the laboratory. They understood that building a well-thought-out governance and communications framework was key to achieving this goal. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Executive Speechwriter for AHA. Join us to hear the story of how the Henry Ford Health System developed and implemented a framework connecting clinicians and laboratory professionals from the ground up, which not only improved collaboration, but also removed process waste, improved patient outcomes, and delivered process efficiencies. Today's podcast is brought to you by the College of American Pathologists.
Welcome. I'm Elisa Arispaguachaga, Vice President of the AHA's Physician Alliance, and today I'm pleased to have with me Dr. Gaurav Sharma, Division Head of Regional Laboratories, Department of Pathology and Laboratory Medicine, and Dr. Richard Zarbo, System Chairman, Department of Pathology and Laboratory Medicine, both at Henry Ford Health System in Detroit. Welcome, and thanks for talking with me today.
Thank you, Elisa.
Let me start with you, Dr. Sharma. Can you give us a little bit of an overview of the lab at Henry Ford and the volume of testing you see and the costs associated with that?
Henry Ford Health System is a comprehensive, integrated, nonprofit healthcare organization that is based in Metro Detroit, and we are a part of that. Our health system was founded in the year 1950, so that is more than 100 years ago, by the automobile pioneer Henry Ford. Now, we serve more than 3 million residents of southeastern Michigan through more than 3,000 physicians who are either a part of or are affiliated with our health system. Within this system, the pathology department is a clinical service line that oversees testing at more than 70 CLIA 88 licensed locations. In 2020, our gross revenue was north of $700 million. And we generated over 30 million lab results. We are an integrated laboratory network under a dyadic leadership model with a physician system chairman and a system vice president of laboratories. I have been with this organization for more than 10 years. And in my experience, there are many things that make our department unique. Our focus is on high quality and high reliability. And I'll defer to Dr. Zarbo to explain how leadership at his level sees what we do.
Sure, Dr. Sharma. Let me put this in a broader context for our audience. You all likely know that about 1/5 of our economy is healthcare, and more importantly, you also know that laboratories touch just about every patient, and laboratory results inform most healthcare decisions. And overall, the lab expense is said to be about 3% of the healthcare spend. So wasteful use of that laboratory testing is a component of waste in our health system and in our greater economy. So this is an important focus. Now, our quest to reduce costs and to improve quality, we've been practitioners of lean since the early 2000s, and our hospital sites are also accredited to the voluntary international ISO 15189 standard through the College of American Pathologists. So over the years, we've created this as an integrated, standardized system clinical department composed now of 6 hospitals and over 30 medical centers, overseen by a professional employed group practice of 42 physician pathologists and additional 8 clinical senior scientists who oversee all testing across the health system. So it's through this design that we intend to leverage value through this structure for our system and for the patients. And we tend to do this in a very high quality, but also a low cost manner. So this integrated lean lab system really has been our business model since 2009, and this is actively supported by system leadership at all levels across the organization. As a matter of fact, we are the lean trainers and have trained thousands across the entire health system since 2009.
And I see a lot of this clearly calls for some close collaboration between your team, the hospital administrators, the directors, all of the clinicians. Can you talk a little bit more about how you identified that need and where you took it?
When lab testing is not in sync with the clinical encounter, it leads to unnecessary delays and waste across all other departments in the hospital. So you can think of lab services as the electric grid. You don't notice it when it's working. However, the moment your electric grid trips, everything comes to a halt. I think we learned a lesson about the importance of lab testing during the COVID-19 pandemic. We needed this information in real time, and we needed the labs to be there. Even otherwise, whenever you're seeing your doctor, there is a high chance that a lab test will be ordered or a result will be discussed. You see, the laboratory is one department that has to work well with all other hospital departments on a daily basis and for almost every patient. When your lab slows down, everyone else slows down. Therefore, the need for a close collaboration.
Let me just add something about that question about collaboration, Elisa. So we foresaw a long time ago that to be a great lab and to achieve our own internal goals, we really need to be great collaborators. So our cultural DNA through this continuous improvement culture has been to seek excellence in all that we do. And this is facilitated by this effective dyad leadership model across the health system that we've described. But for us, that leadership leads and supports our lean and ISO-enhanced structures. So we have built management systems, and this allows us to create innovations in process from the level of the work like no one else. So these laboratories produce over 1,000 process improvements each year. So our model was really the Toyota production system and its culture. And we have applied the same approach to lab test utilization and guidance.
And something that we should all be worried about is the fact that the healthcare diagnostic market has been flooded with tests that have limited or unproven clinical utility, especially in the area of personalized medicine. Now, these tests can cost thousands of dollars, and these costs are often passed to the patient or the health system. Hospital administrators, clinicians, and laboratory medical directors must ensure that high-end lab testing is adding value and not excess costs to the clinical encounter.
This is a very good point that Dr. Sharma raises, because these are the expensive tests that we really need to focus on. And really key to improvement in controlling these costs is for us operating horizontally across the health system in order to be able to standardize and minimize that waste and improve those processes in a continual manner with our colleagues. And I like to look at it this way. We're all really customers and suppliers of each other, in a sense. So we're all stakeholders, and therefore we must all engage together, both the clinical, the administrative colleagues, as well as our lab medical directors, essentially, in creating these solutions that we're all going to mutually agree to own.
And remember, the world has become infinitely more complex in the last 20 to 30 years. In the 1980s, the clinical laboratory test menu was quite basic. Fast forward to 2000s, we are now offering over 1,000 different tests at our laboratories in campus. The time allotted to the instruction of pathology and lab medicine in medical school has been cut back during this time. So clinicians have to understand more, do more, and order more with a limited amount of instruction and experience with each of these thousands of tests. This, in our opinion, is a perfect recipe for over-testing and higher costs. Therefore, the need for collaboration.
You bring up a very good point. So that's a true gap that we experience in a lack in current testing of medical professionals. So in short, what we're really saying is that as pathologists and as lab medical directors, we're in a very good position to contribute our expertise to help our hospitals and our clinician colleagues recover some of that economic value to improve their clinical outcomes through an appropriate approach to laboratory testing. And this really became our initiative to create a laboratory formulary.
It really sounds like you've set up your lab to really be the underpinning to support the entire health system and a significant initiative at Henry Ford. Can you tell me a little bit about how you've sort of brought all of these different groups together and how you appeal to them across the board? Some are incentivized to do some things, others to do other things. And it sounds like you've really worked at developing that collaborative model so that you can best inform everyone. But tell me a little bit more about that.
Let me approach this question from the perspective of a value chain. That is a set of activities that are performed to deliver a final product in any sector of the economy, not just healthcare. And the reason I say that is because when we are trying to start collaboration and identify stakeholders, we have to first understand what is the process, what is the final outcome of their efforts. So in the case of a hospital, the final product is a clinically appropriate and a cost-effective patient care. We want our patients to leave the hospital without high costs and bills. So if you look at it, in this value chain, there are several stakeholders who must participate in the right manner and should have the right incentives and disincentives. And these include our patients themselves, our clinicians, the IT department, of course, the lab that must perform testing, and let us not forget the payer or the financial guarantor who has to incur the cost of treatment and of lab tests.
Yeah, I think as Dr. Sharma described, as you can see, everyone owns the cost of healing, essentially. Embedded in that is that small cost of laboratory testing, and that testing can significantly influence roughly 70 to 90% of the clinical actions, and those result in the cost of the overall system, essentially. So that's the trigger. And let's not forget that most of us report to a boss. That boss sees life in a different way. So that boss has a budget, and they have budget targets in order to keep that ship afloat so we can continue to do what we do professionally. And they're ever seeking to improve their position as a system in the marketplace. Essentially, there are many stakeholders at the very top. The CEO, the CFO, the hospital board, they're all interested in controlling costs. And then at the point of impact, at the bottom, we've got the patients who also see those costs, but perhaps they see less the quality of those services received. So they're focused on cost as well, and they're out of pocket, especially with high deductible healthcare currently.
And beyond that, let us also be aware of the fact that value-based payment and penalties are here to stay. Those are a special case of incentives or disincentives to collaborate. When payment is based on quality indices such as catheter use associated UTI or CAUTI, the health system and its leaders must be very prudent to ensure that there is no overuse or misaligned use of lab tests. Because if that happens, or if it goes unchecked, it can lead to excess penalties and losses for everybody in the health system. That, I think, is a big driver in the future.
Let me just add, I see life through lean eyes after 18 years of being at this now. And that really is a focus for us on the way Deming would look at this, on the appropriateness of testing, the efficiencies, and the costs. He would think about improving the internal processes in order to get efficiency. So this is really about resulting in a reduced internal cost and therefore a competitive advantage in a healthcare system. Being able to offer contracts, for instance, at higher value, higher quality, less prices. So this then really is the value, something that all stakeholders are interested in. How do we reduce the overall cost of that episode of care? So who should take the lead in fixing these problems? If we look at the Choosing Wisely initiative, over half the physicians in one of their surveys felt that they should be involved with such lab utilization decisions, and they wanted to partner with us in such initiatives. Up front, that may be a scary thought until you frame it in a win-win scenario. So how do you frame it by bringing people that you thought were your enemy into being your friends and colleagues and collaborators to create something that is bigger than the both of you?
Absolutely. And to that point, can you tell me a little bit about some of the challenges and barriers you faced as you tried to get all of these ships going in the same direction?
There's many. To borrow a phrase, it takes a village to make this kind of a change. So really the solution is to create your village towards this purpose. Therefore, you got to take into account and achieve buy-in from numerous stakeholders and numerous users. So often there are really no financial gains or compensation for doing the right thing in life, but there are, in this instance, both quality and efficiency dividends that can and should be demonstrated to these stakeholders. I can tell you by 2014, we had already come from a 14-year success in reviewing new lab test requests and their appropriateness, as well as the new technologies, for a formal in-house lab structure we had set up. We call it the Clinical Lab Evaluation Technology Assessment Committee, or CTAC for that mouthful. This process was very effective, but it was internal to lab alone. And one of my mentors told me when I first started out, he said to me that when the job of a pathologist is that of a policeman, it can be a very interesting job, but also a very short one. So this was not going to be our approach because we realized that we were not going to be able to tell people what to do. So our next vision essentially was to engage our clinical colleagues in the lab test decision-making, as well as the ownership of that new lab testing and these technologic changes. So think about that. Your users are going to take ownership now for the cost of the testing that they're doing. So we began this by creating a strategic plan for a system-wide lab test utilization optimization. And this was going to include us in the laboratory, our clinical medical leadership, as well as our administrative and finance representation across all the hospitals of the system. But first, I have to tell you that I wasn't about to jump off this platform without a parachute. I went and had this process sanctioned by our senior medical leadership. This was a proposal, and this was something that I offered to them if they wanted us to pursue.
And I think going back to the example of the village that Dr. Zarbo mentioned, a good village is the one that can grow and prosper. And the underlying basis to do that is to become a functioning democracy, where everyone has and everyone feels that they have a fair shot at expressing their opinion and contributing to the best of their abilities to the greater good. So we wanted to make sure that all our stakeholders were well informed. Decision-making was done based on agreed upon criteria, and solutions were hassle-free, efficient, and logical. Now, to do so, there were three main barriers. The first one was a lack of a clear authority to control our send-out tests. Because if we did not have a formulary-like mechanism, clinics could bypass our system labs and send out expensive tests directly to outside labs. So that put us at risk of high costs. The second barrier was a lack of a social contract. While policing is essential, it must be agreed upon. And every time the lab started a discussion or put forth an objection to an expensive send-out, there was always a potential to devolve that into an us versus them duel between the clinicians and the labs. So how do we overcome that barrier? The third was lack of documentation or a lack of a process for making sure that there was consistency in decision-making and agreements. So that was very helpful if we were to go back to our earlier decisions so as to guide our later decisions. Clinicians like care to be standardized and consistent. So they want the same answer every time, and there cannot be any favorites. So we wanted that documentation to be in place. And to overcome these three barriers, we had to first agree to a basic set of criteria to decide which tests should be supported and which tests should not be supported, and who and how that call is made. So we consulted a group of clinicians and other stakeholders, and we came up with three criteria. The first was, is the test in question part of a national or international guideline? The second question was, if the test is a proprietary test, is there enough comparison available to compare it to other tests? And does it actually come out as a superior test to the alternatives? And finally, is the test in question really makes significant change in the diagnosis or management of the patient? Now, if the answer to these three questions was all yes, then obviously we should support that test. If the answer to any of these questions was not a resounding yes, then we really needed to take a pause and understand what we wanted to do. So here is what we learned, that these three predefined criteria removed all stakeholder bias or perception of bias, as we all agreed to play by the same rules before the game started. Like any team sport, we must make the rules before starting the game and refrain from making the rules or changing the rules while playing it. And I think that was the recipe of our success.
I like that, although I don't think that worked really well with my little sister when we were kids, if I couldn't make the rules up in the middle. I really love the idea that you took the time you needed to collaborate and build that sustainable process. Sometimes it's challenging at the front end to say, we're going to take the time to establish what we really want at the end so that it can be sustainable. So what surprised you during this project as you were doing this work, and you clearly have years of history in driving some of these processes across your organization? Was there something specific that surprised each of you? And then some of the lessons you may have taken home beyond this need to build that collaborative, sustainable process?
As far as surprises, I think the first big lesson was that you really need to dare to think big. Senior leadership was very open and supportive of the laboratory leadership involving themselves in this space. And as I said, when I first presented the concept to my medical boss for permission, he actually looked at me and said, that's interesting, good luck. But he didn't say no. And so if you don't tell us no, that means that it's a green light. So we went ahead with that. The second, I think, surprise was that you really need a governance structure, an implementation structure. That's key. You've got to convert it from the win-loss game to a win-win game. And as Dr. Sharma outlined for you, we had the criteria, and that really guided how we created governance and its structure and its rule. And then we insisted that that structure actually translate its value and demonstrate its value, so it was very visible as to what this committee was doing. And then finally, the other surprise, and it shouldn't be much of a surprise, and that's keeping the customer happy. So you've got many, many customers, and you keep them happy, and they're going to keep you in business and give you rave reviews as well. So those were some of the, I think, surprise ahas we got from doing this in a team-based fashion.
And I think I'll also add that a big surprise was the level of support and cooperation that we got from all our stakeholders in the system. Laboratory testing may or may not be the highest priority as a system integration project, but in our case, it was. And I think a lot of it was driven by how we approached what we were doing. We learned that we had to be a provider of solutions, not just the ones who are bringing in problems. Our partners have limited time and limited patience. So to do something well, you have to be well prepared and go in with the solution before you present a problem. Another surprise was the fact that our success was recognized in the Choosing Wisely arena. Many of you may be aware that American Board of Internal Medicine has started the Choosing Wisely campaign. And our efforts were recognized in 2017, 2018, and 2019. So clearly, we must be doing something right.
So how did you overcome some of the barriers and challenges at Henry Ford?
We began by creating a laboratory formulary committee. And we did this for two reasons, both to found a governance structure and also to provide an implementation body, in order to give ownership for this process or to have skin in the game, if you would. So there was accountability for any ongoing assessments for lab utilization. And it also allowed these actions by this committee to be standardized across the entire healthcare system. So we began by recruiting medical representation from each hospital, and we usually started with the CMO. But we also incorporated our employed as well as our private practice affiliated network. So it's easier to do things in the employed practice. We're all part of the medical group, but we have an equal number, 2,000 of private practice groups that had to also adhere to the standardized manner. And then we also sought representation from key clinical departmental users. Eventually, we also included the medical director of our wholly owned insurance health arm. We put that one up to a vote for the committee. And why would we do that? Because they have a say in what they're going to reimburse. And a lot of that molecular testing was not acceptable to them. So we thought it'd be helpful to have them at the table as well. And I'd say to sustain this process, we really leveraged two approaches. Number one, as Dr. Sharma mentioned, we created recognition for participation in this process. And we did this through national recognition through that Choosing Wisely Champion Award. But I think more importantly, we created a financial roll-up of this committee for visibility. So this formulary committee was charged with an annual summary of their effectiveness. Number one, in controlling costs by listing them out and what that run rate was for the year, summarizing these new tests that were approved. And then they were also able to take credit for costs avoided. So costs that were designated to be in the off formulary pathway, if you will. But over a period of, I'd say within a year and a half, eventually this formulary was embedded in a system level council structure. So this was now grabbed by our leaders at the system level because it was recognized for its system-wide influence and its impact. And the executive leaders of this health system have highly supported this structure and its stewardship work in lab utilization to this day.
So let me add to what Dr. Zarbo said. So there were 5 specific decisions that helped us in getting this right. First of all, we identified clinicians who were both willing and able to partner on lab utilization efforts. We wanted on purpose to make this a co-led effort. It was not lab-led, it was not clinician-led, but it was a partnership. Next, since we are lab folks, we love process and we love consistency in what we do. And many great ideas die a natural death at a committee because committees lose momentum after some time. To avoid this, we established a regular meeting cadence that set monthly meeting dates. We set the agenda before the meeting, circulated it beforehand. We asked people to come prepared to the meeting. We documented the minutes and we retained records for future reference. So that helped us to keep this moving forward. Next, we created a simple web page to intake requests for all new tests from clinicians. The web page asks clinicians to share their rationale for choosing this test or requesting this test and any other details that they wanted the lab to be aware of. So it created a special and dedicated communication pathway that was convenient for clinicians and administrators. They were no longer beholden to phone calls or trying to find someone who can give them information or the next step. Everything was upfront and on the web page. Then something that is unique to our organization is off-formulary pathway. And this was a special pathway for tests that were novel or too new to be really evaluated in detail or met some of the criteria of our previously defined 3 criteria. And if the patient and the clinician really wanted some test, they could use this off-formulary pathway as an alternative pathway and send out the test without really putting the system at risk. And as an adjunct to this, we also created an appeals process if the clinician thought that their test deserved an on-formulary designation rather than off-formulary designation. And that appeal was not heard by the laboratory leadership, but it was actually heard by the system clinical leadership. And I think that brought in a sense of fair play. And finally, as I mentioned earlier, everything was documented and all these deliberations and decisions were made transparent.
So to wrap us up, can you tell us a little bit about how this initiative has really affected your overall outcomes, operations, financial, and the impact on patients and patient care and quality? How has it made a change to Henry Ford?
Sure. Let me just start with that lay term, show me the money. This medical lab formulary committee was very successful. So in the past 5 years alone, it has achieved over $5 million in savings to the system. This committee also appropriately classified 103 send-out tests. So we understand what we're dealing with. But significantly more savings were used in guiding the proper use of the laboratory. Essentially, when you think of the 30-some-odd million tests that we deal with, so appropriate use of those lab tests, there are savings associated with that as well. And then in the category of cost avoidance, well, let me go to cost acceptance. So what they cost us over that 5-year period of time, $160,000. So I'd say that's a pretty good ratio, right? Save 5, spend 5 million, spend 160,000. It's kind of like a 1-to-30 ratio in the cost avoidance, cost acceptance. That's, to me, a big success, financial outcome. From my perspective, another main outcome is that this system laboratory has a very prominent system-wide recognition for this lab formulary process. So the lab pathologists are the subject matter experts who feed their expertise and infuse that knowledge and review these testing requests for this lab formulary. So we're kind of the Marines for this system. So this has led to a very sound process with appropriate utilization in a cost-minded manner. And then we talked about recognition at the national level with choosing wisely. So we were very proud that in its first year, this lab formulary actually was recognized by our own annual Physician Network Summit and received the Top Honor Practice Excellence Award by our own clinician colleagues. So whereas I talked about the policemen where we didn't want to be doing things to people, we actually engaged them in the process and they actually recognized its value and were able to recognize this as a system asset. And, to this day, this formulary is still showcased at many meetings and many grand rounds. And Dr. Sharma and I have given many talks around the nation about this as well. So kind of a positive outcomes that I see from lab formulary.
So apart from the cost avoidance of over $5 million over a 5-year period, we have also been able to reduce the inpatient testing costs by over 10%. We have reduced excessive urine cultures and blood cultures across the system. And that is a great win when we are talking about value-based payments. We have also done small changes that have yielded big savings in the long term by giving smarter names to tests in the test menu. Remember, clinicians want something that is convenient and information that is available when they're ordering the test. And there can never be an easier way to do so than by changing the name that helps them make the right decision. And we were able to do all this without hiring extra IT analysts or extra lab personnel. So in a way, this is all gain. The reality is that whatever we did was with the aim of improving the clinician's workflow and reducing costs for the health system. And we feel that by doing these two things, our work was valuable. And perhaps those are the two core guiding principles for us. What we want to do is make lab testing easy, make it convenient, and make it cost effective. And good things just followed.
Let me just add, our medical and administrative leaders are very content that we as a laboratory are doing collaboratively all that we can do to control those lab test costs. And in this current biotech environment where it seems there's a new advanced therapy a week, often with an accompanying multi-$1,000 lab test that's pitched either directly to our patients or to our clinicians, or you're watching it on the nightly news, this is constant traffic that we have to deal with here. And the formulary is a sound mechanism for dealing with this constant test traffic. And it's done in a scientific, medically sound, and collaborative basis. So this has become our entrenched way of approaching laboratory testing in the Henry Ford Health System.
And I think we must acknowledge the role of the College of American Pathologists. They are our accreditation partners in whatever we do in the laboratories. And I think their lab improvement plan and the lab accreditation plan helps us make sure that the testing we do is accurate, is reliable, and is timely.
It sounds like you have not only found the way to support your health system, but really to support your colleagues and your patients across Southeast Michigan. I think that's amazing. So Dr. Sharma, Dr. Sarvo, thank you for joining us today and sharing Henry Ford's story. For those of you who'd like to learn more about the College of American Pathologists, please visit www.cap.org. Thanks again.